Forward. All right, so welcome everyone to our speaker series. Today we're going to talk about nursing perspective in eosinophilic esophagitis, diagnosis, management, and health disparities with Amanda Troger and Dr. Sharma. So I will quickly provide their bios just so we all know who they are. So Amanda is a research nurse coordinator at the Division of Allergy and Immunology at Children's National Hospital. She's a registered nurse with over 12 years of experience in the Allergy and Immunology Division at Children's National Hospital in Washington, D.C. During her time, she has cared for children in both clinic and research settings. She served as the nurse coordinator for their multidisciplinary eosinophilic esophagitis clinic. Amanda holds a master's degree in nursing education, and her interests include patient advocacy and education, food allergy prevention and care, eczema, eosinophilic esophagitis, and venom allergy. She aims to expand the public's knowledge and understanding of food allergies. So welcome, Amanda. Dr. Hemant Sharma, he is also at the Children's National Hospital, and he's a professor of pediatrics at George Washington University School of Medicine and Health Sciences. He's a board certified in pediatrics and in allergy and immunology, and is a fellow at the American Academy of Allergy, Asthma, and Immunology. American Academy of Allergy, Asthma, and Immunology. He has served as the site director of the Allergy Immunology Fellowship Program with the National Institute of Health, and he's a director of the FAIR Clinical Network site at Children's National. Dr. Sharma completed medical school at Columbia University College of Physicians and Surgeons, his residency and chief residency at Duke University, and pediatric allergy and immunology fellowship at Johns Hopkins. During fellowship, he completed a master's in clinical epidemiology at the Johns Hopkins Bloomberg School of Public Health, as well as fellowship in health media at NUMERS. He joined the faculty at Children's National in 2008, and his area of clinical advocacy and research interests include racial and socioeconomic health disparities and community-based management of food allergy. And due to his effort on behalf of the food allergy community, he was selected to receive the 2016 Fair Vision Award. So welcome. I am going to stop sharing, and if I'm not sure, Amanda or Dr. Sharma, which one of you is going first?
I'll go first. And do you want me to pull up the presentation?
You know what?
Or are you going to do it?
I wasn't able to open yours. I was able to open Dr. Sharma. I don't know why yours was having some issues with maybe firewall.
It should be all together. I believe we're both.
It's the same slide? Okay, if it's the same,
Yeah.
Mm-hmm.
It should be, unless you did
something. It's two separate, yeah.
Oh, they are two separate?
Yeah, because I couldn't edit the link. So let me know if you need me to share, Amanda. I have it pulled up as well.
You have both of them?
Yeah.
Okay.
Thank you so
much.
If
you could, that would be great.
Sure.
Okay, we'll save questions to the end. If you have any questions that are urgent, please put them in the chat and we will ask them as we go.
My computer restarted just as the meeting was about to start, so I lost everything that I had open for this. All right, so thank you so much, Olga. As she said, I'm Amanda and Dr. Sharma with me. Years ago, when I was working as a EoE coordinator, we worked together in a multidisciplinary EoE clinic. So these patients are kind of near and dear to my heart, and they've got a pretty complex process. And so there's a lot of little tips and tricks and stuff that I wanted to kind of share with everyone to go through about identifying and presentation, along with nursing care models on how to care for our patients as well. And then Dr. Sharma will talk about the disparities among patients with EoE and some of the information and research that we've seen with our population in a urban setting regarding patients that have EoE. So eosinophilic esophagitis is chronic inflammatory response to allergens in the esophagus. So basically, it's that inflammation that is caused by different allergens. This could be food or environmental, And it causes the eosinophils to build up in the esophagus and cause this inflammation, which then can lead to fissures and strictures and narrowing and difficulty in peristalsis of the esophagus. It is not associated with IgE allergens. So as we'll go through later on in the slide, certain tests that look at IgE testing isn't going to be very helpful in diagnosing and working with our EoE patients. So there's many causes that could lead to eosinophilic esophagitis. So you've got food, a genetic component, as well as environmental and aeroallergens also can cause this inflammation to occur. So some of the symptoms that these patients will have, so our smaller population, the infants, depending on the age of the child, will depend on some of the symptoms that you're seeing. So our infants, you're more likely to see some failure to thrive, poor growth, reflux that really doesn't respond to any medications, throwing up or upset stomachs, and trouble sleeping. Whereas your child, so older children, are going to have sort of the gamut of symptoms. You've got your food getting stuck in your throat, difficulty swallowing, needing to chew a lot and drink a lot of water when they're eating and drinking to get the food, especially difficult foods to break down for them to be able to swallow. They're also probably going to be lower weight on the scale, have some belly or chest pain, doing a lot of vomiting as well. And then our adult population, rarely you're going to see any weight loss or poor appetite, and it's uncommon to have the chest pain, but you are going to still see the reflux, the trouble swallowing. The food getting stuck is a big component for our adult population that haven't been diagnosed until adulthood. Many of them have get dilated, and it's at that point when they have food stuck in their throat that they get diagnosed. So it is something to keep in mind when patients are getting food stuck or need a lot of water or very slow eaters. So a step guide for EoE. There is an article that kind of breaks it down in this way. I've kind of adapted it to add a couple of new options for families. So the first thing is to have a discussion to look at those clinical features, see what the symptoms are, and is it indicative of having eosinophilic esophagitis. And the next step, which we'll talk about, is having a diagnostic test. So it's a endoscopy with biopsy. And so if the biopsy shows 15 or greater eosinophils, that is the indicative diagnosis for eosinophilic esophagitis. There are many different non-EoE disorders that also could have some that could contribute to eosinophilic esophagitis, esophageal eosinophilia, sorry. So there might be other reasons why these cells are in the esophagus. But it is important to have the biopsy, look at it, and differentiate whether it's one of these diseases and kind of rule them out, and as well as looking at it for EoE. And so I'll pause there. We can go to the next. So when you're looking at patients, as I said, greater than or equal to 15 eosinophils per high-powered field is where you're getting your diagnosis. So these are a couple of examples that doctors and pathologists would write in their report to talk about what they're seeing. And it's really helpful when the GI doctors are able to document it with this specificity where they can say, okay, so it's biopsy number 1. This one is on acid suppressive therapy, and they're avoiding all of these foods. And this patient clearly has EoE, and it's greater than 50 and greater than 100, sorry. So there's definitely a diagnosis of eosinophilic esophagitis. On the next biopsy that they had, they're still on the acid suppressive medicine, and they're now avoiding, and they're still avoiding the same medicine, but we're looking at it. There might be that they were just started on the acid suppressant, and maybe they didn't have it long enough in their system for it to be effective, because now we're looking at it going down. It could be that it's during the season that their pollen is flaring up, and that's why it was so high versus the next time going down. So there's lots of reasons. So having a description with the pathologist and the GI physician and allergist to be able to say what was happening around the time that that scope occurred really can help, especially as this is a long process for diagnosis. So for diagnosis of EoE, the endoscopy is sort of the gold standard. You look at biopsy, you can look at the fissures. You can see these images here that I have where A is a normal esophagus, and then the others are all showing different issues that can happen. So you've got the rings that and furrows, edema. You've got strictures and for exudate. You've got the E is where the biopsy being undergone, and then tight rings, so preventing the food going down as well. So these are visual indicators of issue within the esophagus, and then you have the biopsy, which confirms and talks about it from a cellular level. You can go next. So an alternative, so an alternative treatment or diagnostic test is there's transnasal endoscopy. This does still go down. It gets a biopsy. You're able to visually look at everything. This one goes through the nose. So it goes up the nose and down into the esophagus that way. It is sedation free. So it's just numbing in that area. The patient is still able to be awake. And actually, there's a lot of there's program where they provide a VR system, so the kids can play on a VR system while they're having the procedure done, which is really cool. And I hope it's not just for children, and it'll be great for adults because I would like that. It's a shorter appointment, less time fasting. It really gives you the same results as a traditional endoscopy. There are some limitations to it, so it may or may not be beneficial for all of the biopsies that you need. Some you might need still the esophageal, the EGD, but it is definitely an alternative for patients who are older that might be able to do this for their surveillance scopes, since they'll be getting so many scopes over time. And then there are even more less invasive techniques that are out there. Most of them are really not going to replace the diagnostic or therapeutic benefit of the typical endoscopy and biopsy. There is a pills that will go down. It turns into sort of a foam, and then it comes up and it scratches and pulls up the eosinophils as it goes through the esophagus. So it tells us a little bit. It might be beneficial in surveillance to kind of see, are the numbers changing, but it's not going to give us anything visual for these tests. And many of them are still sort of under research to see the benefits in use in practice. So skin testing, when we're looking at a patient, they have EoE, now we want to decide what we're going to sort of come up with a plan. Skin testing is something that people have thought about in helping curate that plan. Because this is not IgE mediated, it has limited benefits for doing skin testing. Some of the benefits could be a directed elimination diet, though the research and clinical data is not great at supporting doing a targeted with these sensitized allergens. One of the big ones is milk is a very common food to trigger EoE, and yet most of the time milk will not show positive on a food panel that is done. So it kind of, again, is it really capturing what we want to help us with this? Environmental might have a little bit more benefit, mostly because it can allow us to know maybe if the patient is pretty sensitized to pollen and it's in the springtime. It might be beneficial to avoid that time frame of doing an endoscopy, so you're not getting false elevation of, well, you're not getting the elevation of these eosinophils, but it's also not going to tell you whether your treatment is working or not, because the eosinophils are now built up, but it's because of the pollen, not from the treatment that you're implementing, especially on elimination or an adding food back into the diet kind of a thing. So it can muddy the picture. Additionally, if a patient is symptomatic during certain seasons and they're alert and they're sensitized to that season, it might be worth putting them on a short course of a topical steroid to help them overcome that period, so that the eosinophils are a little more settled down, so it's not causing extra symptoms during those seasons as well. So now we have a patient who's been tested, we see the endoscopy, and now we have to figure out what to do. And unfortunately, there isn't an easy answer of what is causing all of this to happen. So having a shared decision model with your patient, having decision-making happen and determining, here are a bunch of different options, what works best in your social life, for the patient, how severe are they, what could we start with and build up to? So we'll go through some of these different treatment options. So the first one is proton pump inhibitors, so your PPIs. These will reduce the acid in the stomach and sort of prevent some reflux. There is a population that is has PPI responsive EoE. It is a subset of EoE, so it used to be your first line treatment in the diagnostic process, and now it is determined to be a subset of EoE. So some patients, you're diagnosed, and then they can try a high dose of a PPI, retest, see how they're doing with that, and there's a potential that that will help put them in remission. For nursing considerations for your PPIs, we want to make sure that the patient is NPO about 2 hours before or 30 minutes after the tablet. So we really want them to be on an empty stomach when they're taking this. If they really can't swallow a pill, especially our younger population, a parent could open it up and pour it into like 1 spoonful of applesauce or a food item that is easy to swallow, that is not a trigger food or not a food that they're currently avoiding for their EoE. So they would put it into 1 spoonful, take that 1 spoonful full, swallow it, and that's it. They're not going to finish the bowl of applesauce or the pouch or any of that. It's just that 1 spoonful. Patients should be on a high dose of this for about 6 to 8 weeks before their next scope. So there is some time. We want to make sure the medicine is really having its time to work through to then be effective and give us accurate information with the biopsy. We'd hate to do another biopsy where it's, well, maybe we'll wait a little bit longer to see if the medicine works. We don't want to put patients through these too frequently. And then for these, insurances issues can come up. Sometimes prior authorizations are needed to get the higher dose of the medication. It's really great to look at formularies and determine what the insurance will prefer. So some prefer omeprazole first to try, others prefer lansoprazole first. So knowing which one might be good to start the family off so they're not jumping around so much. So then there's dietary management for these patients. So you've got your elemental formula. This is total elimination. So pretty much no food or very minimal food. And they are getting all of their nutrition through an amino acid based formula. There's a bunch of them out on the market. I don't think I've captured all of them, but the ones that I have worked with is Neocate, Elecare, Puramino, Alphamino. So those are all some potential products to use for these families who are, it is also benefit when the patient isn't reaching nutritional value. So if they are on any type of elimination and the patient can't get to the full nutrition needs, this is also a good supplement to help them with that. And working with a nutritionist might be beneficial in this situation. Empiric eliminations include 8, 6, 2, and 1 food elimination. Wheat and milk are usually the most common that will trigger eosinophilic esophagitis, but egg, soy, wheat, tree nuts, fish, shellfish also have the potential, as well as many other foods. There are lots of kids who have multiple food induced EoE. And so working through that, you have the option of, okay, are we going to eliminate all of these foods empirically? And then if the numbers and the eosinophils go down, then we start introducing each of these foods independently, one by one, or a group of the foods one by one, and having an endoscopy after the reintroduction of each to see whether or not it made a change, and kind of going through to try to guess, in a sense, or figure out which of the foods is causing that trigger. And it could be multiples. And then directed, which is kind of, I feel, leaning a little bit away from this, but basing it on skin testing and IgE results. As we said, they're not great for EoE because they're not looking at the EoE triggers, they're looking at IgE. Also, maybe based on their current diet, if there's certain foods that are very prominent, if the patient doesn't eat egg like ever, or mayo, or anything egg product, probably not going to be the culprit that causes the eosinophils to build up. Sorry, I have a new cat. It keeps making noise in the background. But if they're eating pasta every single day and a ton of bread, might be worth removing to see if that's what it is that's causing it. For the diets from a nursing perspective, you want to help the families really understand the importance of the diet. So unlike IgE, cross-contamination or very small eating this is not dangerous. It's not something where you need an EpiPen. Cross-contamination and those precautionary labels are not something we need to really be strict about. But at the same time, if they're not strictly avoiding the food, the next endoscopy isn't going to show us anything because they're still having the food in the diet. So we really want them to be on a good, strict elimination of these foods. So it is important for them to avoid it, and telling school and other places that it is important for them to avoid these foods for a medical reason. Once in a while, you can kind of talk with the families and talk with the doctors. Maybe if in the middle of the year and it's nowhere near their endoscopy, it's their birthday and they really want to have food, they're not sensitized, it's not IgE mediated, they can have a bit of a cheat day maybe. But again, it's not near an endoscopy, it's one day, it's something that you can discuss and have that shared discussion with the family, and making sure it's not IgE mediated or they don't develop sensitization so that there's no risk of them reintroducing something. Having a letter for school is very important. And then connecting them with nutrition and psychology, if possible, is really, really important for these families, because they're going into it looking at no, 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 rather than, okay, but here's all the food you still can eat. So helping flip that thought process of, instead of what's being restricted, it's what we can eat and what can be opened up for the families instead, is really helpful. Since this is a very long process and these kids are now doing something that's different than their other friends. And it definitely has its own stressors as well. So just idea of some of the formulas. So you've got your amino acid-based formulas. These do not contain any intact proteins or peptide chains. So they are sort of the cleanest when it comes to allergenicity. There's really nothing in them that would cause reaction and help. Hydrolyzed or ultra fully hydrolyzed formulas, there is still the protein structure that's in it. It has been broken down. So kind of in a sense of baked milk versus direct milk. So your protein structures are broken. So some families might be able to tolerate those. But it is something that you still have the protein. So patients may still react and get eosinophils based off of because of the hydrolyzed formula. So the amino acid based is really what's recommended. You go to next. And these are all from a nursing perspective. These are all places where you can get the formula. WIC is the #1 best way. You just tell WIC to give it to them and they will give it to them. And it's the easiest and fastest way to get it through. So if they qualify for that, I highly recommend going through that. But you can also get it through SNAP, Medicaid, and then each of the companies have their own special reimbursement program. They also have representatives who can help with the initial prior authorization process or benefits investigation and figure out what vendor to use and things like that. So I would highly recommend if you have a brand that you're using or all of them, use the website, use the program. There's a form you can fill out, and it makes the process a lot easier from the nursing side of things. And this is not completely up to date, but I had created a sort of a table to remind myself of all of the different products, what is out there. You'll need HCPCS codes when you're talking to insurance companies, knowing the mixing chart information of how much is in each can and how to make the correct calories is really important. And working with a nutritionist can be helpful in these as well. And as you can see, they all come in really fun, different flavors. So the kids can get samples and they can try out the different flavors to figure out which ones they prefer. Neocate has Nutra, which is a thickening product. And so it's like a pudding. So you can use that to help with developmental stages of eating when they have to be on an elimination diet. And then Splash is great for your older kids. It's like a juice box, but it's an elemental formula that's in a juice box for those kids. So one of the drug treatment options that there are is swallowed steroids. So we have the swallowed Flovent, which is now generic fluticasone. And so you have that. So you take the puffer. Actually, I'll describe that in just a second. Sorry. You have the swallowed Flovent. You also have the oral viscous budesonide. So your asthma budesonide, you squirt it into a bottle, into a cup, mix it to make it thick and swallow. And then the budesonide oral suspension, Eosinophilic, is new, and it's a packet that sort of comes. You can go next. So I've created, and I'm sure there's others out there, instructions for families, because trying to describe this in the clinic and then going home and remembering the steps is kind of hard for some families. It comes in 44, 110, and 220. Basically, the patient takes the inhaler, takes it up, puts it in their mouth, no spacer, presses the button, and swallows. And depending on how many puffs they need, they can do it a second time and swallow. So in this case, we do want it in the mouth. We do want it to hit the back of the throat, and we want them to be able to swallow it down. And essentially, it's topical. It coats the esophagus. No eating or drinking for about 30 minutes after taking the medicine. You can rinse out your mouth and spit, and that will help reduce like thrush and any of those other side effects as well. But we want to make sure they're not swallowing the water when they do this. For oral viscous budesonide, so you take the bullet for the budesonide, squirt it into a small cup, and then you mix one of these potential options with it to create it into like a thickening viscous solution so that, again, You drink it down, and it slowly coats the throat again as that coating to reduce the inflammation in the esophagus. Again, we're not eating or drinking anything for 30 minutes after. This is still a steroid, so you have the side effect of thrush and other aspects. So rinsing the mouth, spitting, not swallowing can help with any side effects that the patient might have for that. But if their family does not want to mix with any of those products, or it's difficult, or they're not able to get certain medications or anything, Eohilia is a new FDA-approved product. It's a liquid-like form of budesonide that is designed to treat the inflammation. So it's the budesonide that we just talked about, but in an already made pre-mixed packet. So it's got a individual packet. You take one packet out and you shake it up and then just squeeze it directly into the mouth. And you then wait 30 minutes, no eating or drinking. Again, rinse out the mouth to prevent any of the side effects as well. So. And lastly, another option for patients is Dupixent. So Dupixent is a first and only FDA-approved treatment that helps manage EoE in patients age 1 to older and older. It inhibits the IL-4 and IL-13 signaling and impacts the pathological changes and symptoms of EoE. The patients would do 200 or 300 milligrams every week or 2 weeks. It is an injectable. It is subcutaneous. They have a pen version, so you don't need to see the needle or anything. It can be self-administered. The thigh, stomach, or back of arm, or parents can administer as well. And there is a syringe form for in the office, or if some parent is administering it as well. Most insurance companies will be covering this now. There are still a few that need prior authorization, but it is becoming more prevalent on the formularies as a treatment for EoE. So it is getting approved easier from insurance companies for the treatment of these patients. And then lastly, if a patient doesn't respond to any of these things, or they're been late to be diagnosed, there is endoscopic dilation. So endoscopic dilation, it opens the esophagus from narrowing. You have a balloon that goes down into the esophagus to the arrow of that narrowing space, and it opens up and widens the space to help the patient so the food doesn't get stuck. There are risks to it, just like any type of procedure, but it is minimally invasive. But it's not a long-term treatment. You know, the narrowing, if we're not going to stop the disease process, the narrowing can come back and they can continue having issues. So it's kind of a temporary Band-Aid in a sense. And as I said, many cases, this is how many adults or older teenagers are diagnosed for the first time. They have food stuck, they get a dilation, and they do an endoscopy with biopsy at the same time, and it shows elevated eosinophils. So I guess we'll pause on the questions for me until Dr. Sharma goes.
Yeah, I think that's a good plan.
Perfect. But thank you guys for that, and I will pass it along to Dr. Sharma.
All right.
Okay.
Thank you, Amanda. That was an awesome presentation, an overview of EoE. It's a big topic to review, and you did a fantastic job of covering it. Amanda and I have been working together, gosh, for like many, many years. And I always say, whenever I talk about how much I enjoy working with nurses, Amanda's one of the first people I think of because she is the nurse that I've worked with the longest. She came to our division right out of nursing school and has just been an amazing clinical partner in the care of many, many patients. And as she mentioned, for many years in our multidisciplinary EoE clinic. So this is, it's an honor to be able to present along with her. So thank you again, Olga and Fana, for this opportunity. So briefly, we wanted to talk a little bit about disparities in EoE and food allergy. And this is an area of research interest for me. So we know quite a bit about disparities, in particular for asthma, and we're beginning to learn more about disparities within IgE-mediated food allergy, but much less is known about racial, ethnic, and socioeconomic disparities in other atopic conditions, particularly EoE. Our group in 2014 was one of the first groups to report apparent racial differences in EoE clinical presentation and symptoms. And this was among the first 50 patients in our multidisciplinary EoE clinic at Children's. So some of what we found, you can see on the left here in figure 1, there was a significant difference found in comorbid atopic dermatitis, with African American or Black patients having much higher likelihood of having comorbid eczema compared to white patients. There was also a difference in those presenting symptoms of EoE that Amanda had discussed. And so she reviewed how it can differ by age, but it also appears that there are some differences by race in terms of how EoE may present. You can see on the left here, African American patients much more likely to present with failure to thrive, and also more likely, significantly more likely to present with vomiting or reflux. No differences in abdominal pain or dysphagia presentation. Now, one of the things that was very interesting was the age of presentation. So we found that there was a significant difference with African American children having a younger mean age of symptom presentation and formal diagnosis. And so you can see here, the age of diagnosis for African American children in our cohort was about 3.5 years old, whereas for white children, it was nine years old. And this was highly significant. There was also a trend towards a longer interval between symptom onset and diagnosis. And so and you can see the interval for African American children, 2.1, and then for Caucasian children, 1 year. So that suggests that even though they may develop symptoms at a younger age, African American children may have a longer gap before they actually get formally diagnosed. So over the past 10 years, there hasn't really been that much additional research looking at disparities in pediatric EoE. There have been other groups that have done similar retrospective cohort studies, and I wanted to present the most recent one, which was actually quite large at Children's Hospital of Colorado. Between January 2009 and December 2020, they reported data on over 2,000 children in their clinic presenting with EoE. And one of the things that has evolved in the disparities literature within that time frame is that we have a much better measure to characterize socioeconomic disparities using what's called the Area Deprivation Index, or the ADI. And this is used to categorize neighborhood advantage versus disadvantage. So a couple of the key initial findings, and this corroborated one of our findings back several years ago, in that Black children were younger in this Colorado cohort than white children at diagnosis, 8 years versus 10 years. They also looked at children from rural areas and found that they were younger at their first visit compared to other children 2 years old versus 4 years old. With regard to the ADI scores, children who had a higher ADI score, meaning that they had greater neighborhood disadvantage, had less radiographic evaluation of their disease, and also had esophageal dilations at younger ages. And so this suggests that there may be socioeconomic factors that contribute to perhaps poorer access to healthcare, poorer access to specialty care, to radiographic evaluation, and as a result of that, more rapid progression of perhaps unrecognized disease requiring dilations at younger ages. And I already mentioned the age difference, which was consistent with prior studies. And this suggests that perhaps there's greater disease severity among Black children compared to the white counterparts. And another difference with regard to rural children from rural areas, they were seen less frequently by feeding therapy, but were also younger at their first visits. So a number of differences were identified here that have been corroborated in other studies. The authors rightfully note that there really isn't a biological basis for these observed racial disparities in EoE. And instead, what this more so likely reflects is a complex interplay of various underlying systemic factors. They talk a little bit about specialist referral because that appears to be one of the key factors that could underlie some of these racial and socioeconomic differences. There's a lot of research to show that Black patients have fewer specialist referrals overall compared to white patients. And patients with EoE have been reported to often make adaptations to their eating in order to address symptoms for quite a while before they actually eventually seek medical evaluation. So the authors hypothesize that that only Black patients with more severe symptoms may be those who end up eventually getting evaluated by specialists, and so that could underlie what appears to be this difference in terms of morbidity of EoE by race. So this is a table or a figure taken from this paper that just summarizes, some of what we know from the literature, in that children diagnosed with EoE are more likely to be white, non-Hispanic, English-speaking, and from socioeconomically advantaged neighborhoods. And that there are a number of determinants of health, both racial and social, that impact the presentation and the care of kids with EoE. And so health policies really should be focused on promoting equity within the care of children with EoE. So what are some of those proposed solutions that could be implemented to reduce disparities in EoE? This is from another paper that came out last year in 2024, and they categorize these solutions at the level at which they are directed. So at the policy level, one of the things that is being advocated for is universal coverage of elemental formula as medical nutrition, and also expanded health insurance coverage, because that could be one of the reasons why patients may not seek care with a specialist because of the cost associated with that. At the institutional level, increase access to specialty care providers for follow-up, leveraging telehealth, providing transportation assistance. Within our division, we have a health equity initiative. And so one of the things that we do as part of that initiative is we do a food insecurity screen for all of our patients. And if they screen in, then with the assistance of our social workers, we identify what those barriers are. Do they need copay assistance for medication? Do they need grocery cards to be able to afford specialty foods? Do they need transportation or gas assistance? So that's one of the things tangibly at the institutional level that we can do to help address that barrier to care. Also, access to specialty pharmacy services. So for medications like Dupixent, we rely on specialty pharmacies to provide that to patients. And so working together to develop a good relationship. If your own organization has their own specialty pharmacy, that's even better, but that can help improve access. Specialty level solutions include things that we within the allergy immunology community can do. We're doing one of them right now, which is education to improve awareness of EoE and EGID, eosinophilic gastrointestinal disorders. Also, accurate characterization of the demographic distribution of EGID. So for many years, there was a thought that, a child who wasn't necessarily white shouldn't really have a high risk of EoE. But as more and more cohorts have been reported that show that actually at some centers, the distribution is very different than what previously been reported, and that we really should keep our eyes open for this condition among children of all racial and ethnic backgrounds. And then at the level of the healthcare provider, shared decision making. Amanda talked about this, and so EoE is one of these conditions with an allergy that is complex in terms of selection of treatment. And as more treatments emerge, like Dupixent, like Eohilia, that shared decision making becomes really important. And then educational materials for treatments that are developed to reflect patient diversity and differences in educational background. And again, at the patient or caregiver level, just participation in the shared decision making. So I am going to pause there because I want to make sure we leave time for questions and discussion. I had another segment. I wasn't sure how our time would flow tonight, so I have another segment of the talk about my research within what's called the FORWARD study. FORWARD is an NIAID-funded multi-center study that's looking at health disparities in IgE-mediated food allergies. So different topic, but somewhat related because it's also about disparities research. But happy to come back another time if you'd like to talk about that. But I just wanted to, again, thank you for this invitation. And Amanda and I would be happy to take questions or just comments that you may have. Thank you again.
Thank you. We'll definitely have to have you back because there's a lot to talk about. I'm going to open it up to the floor because I feel like people have questions. And I see somebody put in the chat already. So let's see. Kim, did you want to ask the question or do you want me to read it? All right. So when you say empty stomach for PPIs, does that include other medications, vitamins given at the same time? Is there a best time of the day, AM or bedtime to take PPIs?
With the medicine, the other medicines, I believe in Dr. Sharma, correct me if I'm wrong, you can take those at the same time. Really, we're talking about food. So we don't want the stomach to be full of food. The more empty it is, the more of those proton pumps are open and available for the medicine to then latch and block. So if there is food or other large things in the stomach, it's not going to be able to get to it to be able to do what it needs to do effectively. It is a medicine that still will work even on a full stomach, but it's going to be the best on an empty stomach. It's going to be the most effective and give us the best results if the patient is on an empty stomach. The medication is sometimes a twice a day. So first thing in the morning, last thing in the evening is when we typically would be administering the medication.
Okay.
Thank you.
So any other questions?
Yeah.
Oh,
go ahead.
Oh,
Lena, go ahead.
Oh, thank you. Brilliant presentation. Thank you so much. Really great to actually sit and listen to the context in the US. I just wanted to provide a little bit of context from where I come from in Australia, because I think the health disparity information particularly, I think would be translated in Australia particularly. We have, very, very prevalent health disparities between our Indigenous populations, our lower socioeconomic families, and so that would be reflected here. In Australia, it's really interesting. Within allergy and immunology in Australia is quite varied from all the states, and it would be similar in the US as well. But in Brisbane, a lot of our EoE patients, particularly our paediatric patients, are actually managed almost solely by gastro. So a lot of the time so I work in a private practice, so I'm actually quite unusual. I'm a nurse practitioner. I work in private practice, my own practice, but I contract to a specialist practice of immunologists, allergists, and paediatricians. We work with adult and peds. So a lot of our doctors will actually, if they identify potential EoE symptoms, will send a referral straight to pediatric gastroenterology or an adult gastroenterologist if that's the case. So just interesting looking at sort of the care pathway differences there, for one. So there seems to be a lot of collaboration between immunology allergy and gastro between the three. So the patients are often co-managed, but the direction in terms of medication and scopes is very much run by gastro. So it just wanted to just highlight a slightly different management sort of way that we see it. I've seen a couple of pediatric patients with potential EoE in my nurse practitioner practice. And again, I have written direct referrals to, the gastros that look after them and work alongside with them. So yeah, just wanted to highlight that. But yeah, thank you for the information, particularly about the medications. It's interesting to hear about Dupixent. I'm not entirely sure whether we're using it in Australia for EoE. I think it's on the way, but we use Dupixent for eczema a lot. Yeah. Thank you.
Thank you for sharing that, Lena. Yeah, I was just going to reflect on what you were saying about the gastro referral and kind of that dance, I guess, in managing patients with EoE, because it's complex, and I think it depends in many ways on the local institution. So, I mean, we're fortunate enough that we've had this multidisciplinary EoE clinic for many years, which was developed, I think, in large part to enhance the patient experience, because before, what was happening is that a patient would see, one specialist, and then, they couldn't fully develop the plan because the other specialists needed to be in consultation. And so bringing us all together, along with nursing, along with psychology and the dietitian, has been really helpful, because it's basically a one-stop shop. So the patient comes in, if they've recently had an endoscopy, we review the results together with them. We together discuss the options of what we can do. Once we devise a treatment, psychology might stop in. If it's a dietary treatment, the dietitian might stop in and talk about it right then and there. So they get everything at once, which I recognize is not necessarily available at most places. So, so I think that has been incredibly helpful. But even with that model, we still have patients that can't get into the multidisciplinary EoE clinic because we only have a certain number of them per month. And so I sometimes will see a patient in allergy, and then I'm just collaborating with the GI specialist. But that collaboration is really important, because I think what can happen sometimes is that, given that the GI specialist is scheduling the next endoscopy, we sometimes will have to weigh in and say, well, wait a minute, like Amanda said, pollen season. Pollen is really high right now. You're not going to know whether your milk elimination diet was effective, because it's going to be confounded by the tree pollen counts that are through the roof. So wait, until tree pollen goes down, given that this child is sensitized to pollen, and then do the scope, in a few months. And so that collaboration, I find, is very helpful, because, I've run across some gastroenterologists, not at our institution, but other places, that say, well, what do allergists really have to do with EoE? This is a gastrointestinal disorder. But then, we try to educate and say, well, it's driven by allergens, and so that's our role as allergy clinicians, to kind of contribute to that part of management.
Yeah, I totally agree. I was also just going to say that our pediatric gastros particularly, they do a lot of referrals to our clinic, because their awareness and education about allergy is so high. So we have quite a good collaborative model, but in the private arena, so private practices, but within public, I think there still needs to be more done. But brilliant model, really, really well done. So yeah, thank you. Enough from me.
Thank you so much. It's interesting, because one other thing I think we maybe is very important to underscore is the relationship, especially of patients who are undergoing, let's say, oral immunotherapy, and then perhaps get diagnosed with EoE. And that's where I think it's really important to work with GI and allergists together, because, like you were saying, the foods might be the ones triggering it, and what are the contraindications, and how do you proceed in those situations when patients have to tackle more than one diagnosis and one potentially causing the other, or contributing to the other. So
that's a really good point, Olga. And we, in our OIT program, Anna Sprunger, who's one of the PAs in our group, we have this pathway that we follow, and every time a patient comes in, for their OIT updosing visit, they have to complete their, I think it's a modified version of the PEAS, which is the pediatric EoE symptom scale. And so we're monitoring them closely to see whether they have any new onset GI symptoms while they're going through OIT, because we don't want to miss that, obviously. That's a known, risk associated with OIT. And it would be important for us to identify that early and then refer them to GI for evaluation if it seems like they might be developing EoE related to the treatment. I saw in the chat that Sue, you mentioned that your oldest has EoE and wrote this article on allergic living in high school. I'd love to hear more about it. I think just the title alone, I get the title because from our psychologists in the EoE clinic, that is one of the things that's really challenging with EoE is that, no one seems to get it. It's not, it's not something like eczema that's visible. And then when you say food allergy, everyone thinks of the IgE mediated form, but would love to hear more about your perspective.
Yeah, sure. Thanks so much. I enjoyed that presentation from both of you. I love hearing from nurses in the field doing these things. So yeah, I'm a pediatric nurse. I work in primary care pediatrics as a nurse manager, very busy clinic. We have 8 pediatricians, and I do a lot of the food allergy outreach at that level for the pediatricians, and I'll just go in and meet with families as well as my other care. But working with people that are just newly diagnosed with this and totally overwhelmed and looking for resources. So in particular, this is aside from the article, but when we do have patients diagnosed with EoE, they are really overwhelmed and want to find someone who really understands this. And at this point, I'm in New York, and I'm very not on Long Island, very close to Mount Sinai. And if I say to go in to see Shahadi at Mount Sinai, her waiting list is like over 3 years. So, while I would love the multidisciplinary approach, it's still so hard to come by, even, in areas where people have access, let alone I'm also a public health student. So looking at the inequities and the disparities and what goes on in food insecurity and people with lack of access to specialty care. This is part of our mission with FANA, is like really trying to get out there and help direct people that need some, encouragement and some pathways to care. So I don't know where to send them. So like the other day this happened for someone. So then I was looking up, I texted a friend who uses Shahadi, who said another guy out on Long Island, she recommended because she couldn't get in with her other kid. So it's just this kind of grassroots effort. Is there a list of experts in this area regionally? Like you can go onto the Quad AI site and find an allergist, maybe. Is there something like that for EoE?
In New York, try NYU. They have a big clinic now too. They do EoE.
Who is this?
NYU.
NYU.
Yeah, in Manhattan.
Yeah.
But I don't know if there is a list, so maybe our speakers
There is a program, an organization that I was speaking to at the conference, and I'm trying to remember the name of them. They approached me.
Yeah, the American Partnership, American APFED, APFED. I don't remember what it stands for, but they're the big patient advocacy organization for EoE.
Oh, actually, yes, Sue, I have their information.
Yeah.
They were actually going to be a speaker later this year for us.
Yeah. All right. That's great.
They do have a like a specialist finder on their website where like, you put in your information and then they can bring up like a list of clinicians in your area that are experienced in EoE, both GI and allergy. Okay. And so that's what I've tended to refer patients to if they move out of our area.
Okay.
But it's a challenge because I think these multidisciplinary clinics are wonderful, but to get into them, even ours, is really hard. Like I think our wait is about 3 months right now, which, for a family who just got diagnosed and, they're trying to figure out what they can do immediately, 3 months feels like a lifetime. So, I think just doing all we can to create access locally is very important as well.
Yeah, I know we're in interest of time. We're past an hour, 9 o'clock now here Eastern time. I know we have one more question. If we can maybe answer that real quick, and then before we wrap up, I would appreciate that. That was from Kathleen, and she wanted to know if patients who have increased symptoms during pollen season have IgE-mediated allergy to the pollen. is
Mhm.
allergen immunotherapy helpful or a detriment?
Yeah, great question. So typically, yes, so they would be sensitized to pollen. And that's one of the reasons perhaps to do aeroallergen testing, like Amanda had mentioned, to help identify those patients who might have seasonal flares in their EoE symptoms. The question of allergen immunotherapy is not fully answered because we don't have enough data yet of patients who have gone on AIT, who have EoE, and who also happen to have a seasonal form of EoE to be able to assess whether it helps or hurts. In other atopic conditions, there's kind of this rule of thirds where, like, on allergen immunotherapy, a third might get better, a third might get worse, and a third no different. So I think it's really hard to say one way or the other what the effect of the AIT might be. Just like with oral immunotherapy, it's something that we monitor, but I think that in general, my thought would be that there should be a lower risk of that happening with subcutaneous immunotherapy because the allergens are not directly contacting the esophageal mucosa. And so I can't think mechanistically of why the risk associated with OIT would be increased of having EoE get worse. But typically what we think of as the mechanism for patients who have pollen-induced EoE is that during the pollen season, they're swallowing pollen allergens. It's inevitable. Like, you walk outside, and on those days when the pollen is just coating the car, just being outdoors and breathing that air in, some of it's going to get swallowed. And the thought is that that direct mucosal contact is then what triggers the EoE. And I've had many patients where reproducibly every spring they start having a flare of their EoE symptoms without any change at all in their diet. And so we document it, with scopes, and we show that yes, nothing changed diet-wise, but the season changed and they flared up. And so for those patients, often we can seasonally put them on like a topical steroid treatment before the pollen season starts in order to minimize symptoms from flaring up again.
Thank you so much. I'm going to stop the recording. I appreciate your amazing presentation, very informative.